activities today. Today we have a case presentation by Dr. Sai Deekshith and followed by a PPT presentation by Dr. Jayabharti on blood and blood products. Over to Dr. Sai Deekshith and Professor. Dr. Sai, can unmute, you can start.
Sir, good evening, sir.
Good evening. Go ahead.
Sir, today is my topic case presentation, sir. Patient with sickle cell anemia, posture for LSCS, 36 weeks gestation, and anesthetic management, sir. Starting, sir. Mrs. Kavita, 20 years old, coming from the Chennai, housewife, primary gravida, booked and immunized case with LMP, last menstrual period 15/9/2022, and with the expected date of delivery 27/6/2023, sir. Comes with history of 9 months amenorrhea, found to have anemia and pedal edema, admitted for further evaluation and safe confinement. History of present pregnancy, first trimester, no history of morning sickness, bleeding, white discharge per vagina, no history of fever with rash, no history of drug intake, no history of radiological exposure, history of weight gain present, first trimester scan done and it is normal. Second trimester, no history of excessive nausea and vomiting, no history of pedal edema, no history of headache, no history of blurring of vision, no history of oliguria, no history of spotting or bleeding per vagina. Quickening felt at 22 weeks, around 22 weeks. History of iron and folate intake. Injection TT 2 doses given, sir. And history of breathlessness and easy fatigability is present. Third trimester, history of pedal edema is present, relieved with rest for past 2 weeks. Around pedal edema around ankle and feet. No history of headache, blurring vision, no history of oliguria, no history of burning micturition, bleeding per vaginum. Fetal movements felt normal. Occasional lower abdominal pain present, which is irregular and non-progressive. Menstrual history, attained menarche at the age of around 13 years. Regular cycle once in 30 days, 5/30. Heavy flow lasting for 5 days. Not associated with pain or passage of clots. Last menstrual period is 15/9/2022, sir. 15 September 2022. Marital history since 9 months. Conceived soon after marriage. Not a consanguineous marriage. No history of any use of any OCPs or contraceptives. Obstetric history. Primary gravida 39 weeks and with 9 days, sir. Past history, not known case of diabetes, hypertensive, CAD, bronchial asthma, COPD, TB, CVA, seizures or any thyroid abnormalities. No significant surgical history. History of recurrent transfusions in family for mother is present during her pregnancy and delivery. Personal history, mixed diet, bowel and bladder habits are normal. No history of drug allergy. History of previous blood transfusions present. 1 unit is transfused for severe anemia at the age of 19 and gradually improved after oral iron and folate intake. Regularly for 6 months and along with iron-rich food. General examination. Height is around 156 centimeters, weight is around 70 kgs. Examined in a sitting position, moderately built and nourished, afebrile, pallor is present, no icterus, no cyanosis, no clubbing, and pedal edema is present, bilateral pitting pedal edema, no elevated JVP. BP 126/78 millimeters of mercury measured at the right hand. Pulse rate 80 beats per minute. Regular, high volume, bounding pulse, and with no radiofemoral delay. Felt in all peripheral pulses. no vessel wall thickening is present. Saturation is 100% on room air. Airway examination. External airway normal, no DNS. Teeth normal, no dentures. MPO, MPS, mouth opening is more than 3-finger breadth. Malambati score is grade 2. And temporomandibular joint normal and mobile. Neck movement is normal and full. Thyromandibular distance more than 6.6 centimeters. Spine is normal. No swelling or edema. Lumbar lordosis is present. Coming to systemic examination, CVS S1, S2 head in all 4 areas. Early systolic murmur is present. Respiratory system, bilateral air entry is present. Normal verbal breath sounds heard. No added sounds. Per examination, on inspection, uniformly distended umbilicus is normal. No engorged veins. And no scars are present. On palpation, in supine position, leg flexed at knee. Height corresponds to the 36 weeks. Flanks free. First, leopard fundal grip, soft, broad, and irregular. Sign of suggestive of breach. Second, leopard umbilical grip. Right, smooth, curved, and resistance pull, suggestive of back. And left, small, knob-like irregular parts, suggestive of limb buds. An auscultation, fetal heart sounds heard. Right side in the umbilical line, 140 per minute, which is regular. And my provisional diagnosis is 21 years old, 9 months, 6 days gestation with expected date of delivery on 27/6/2023 with a cephalic presentation with a single fetus associated with anemia and perial edema. Breathlessness would likely to make provisional diagnosis of anemia and anemia complicating pregnancy with features of heart failure. Came for antenatal checkup admitted for further evaluation and management, sir.
The topic given for everybody here shows that it is a case of sickle cell anemia posted for category 1 cesarean section. That is what is being circulated in the information that has been given, isn't it?
Yes, sir.
So where is the question of discussion about sickle cell anemia here? We are just making a diagnosis of anemia. Is it a real case or an imaginary case?
Imaginary case, sir.
Imaginary case. Okay. Have you ever come across a case of sickle cell anemia in our part of our globe?
No,
Is it
sir.
very common in our population?
No, sir. I didn't see the case, sir.
Because a message has been circulated for the last 2 weeks that it's a case of known case of sickle cell anemia posted for category 1 cesarean section. What do you mean by category 1 cesarean section?
Emergency, sir.
Emergency, acute emergency, because both the mother and fetus life is in danger. So that is a acute emergency cesarean section. So if that is the question, this sort of patients, I have come across only one patient, the two from Africa, who came here for some treatment and wanted to have a knee arthroscopy done. That is the only patient I have seen in my whole practice. Whereas this sort of cases are not at all common in our population, but it could be a theoretical theory question can be asked in theory to test your knowledge about the rare. Under what category the sickle cell anemia will come into, or sickle cell disease? But what category you can classify sickle cell,
Hemoglobinopathy,
anemia,
sir.
thalassemia, all these things come under what category?
Hemoglobinopathies.
Hemoglobinopathies. Very good. So it is one of the hemoglobinopathies. So, Kamachi, are we going to discuss about sickle cell or only about anemia complicating pregnancy? Did you brief
Primarily for
Prof?
exam, there he is going for practical exam, sir. So theory part he has already completed, sir.
No, but
So anemia complicating pregnancy.
Complicating pregnancy we have discussed already.
Already, sir. Yes, sir.
We have
Yes,
presented
sir.
that
So,
we have already, but this sickle cell complicating pregnancy we have not discussed so far.
we have not discussed so far, sir. Yes, sir.
So you must have prepared for that.
Yes,
How
sir.
did we
He has
mistake it
prepared
and
for sickle
prepare
cell.
for a simple anemia complicating pregnancy?
Okay, sir.
Sai, do you have any idea about, have you read about sickle cell anemia?
Yes, sir.
Okay, then we can discuss about that with a few questions that we. Is
Okay,
it a
okay, sir.
inherited disorder or is it a acquired disorder?
It inherited disorder, sir. Autosomal recessive, sir.
It's an inherited congenital disorder. So what happens exactly in sickle cell disease?
In chromosome 11, sixth position of N-terminus beta chain of glutamic acid is replaced by valine, sir.
Sixth position of chromosome or
In chromosome 11, sir.
eh?
In chromosome 11, in beta chain, sir.
Beta chain is with the hemoglobin. Is it with the chromosome? Please don't
No, sir.
confuse between the gene and the hemoglobin structure.
Okay.
The 11th chromosome is the transmitting gene.
Yes, sir.
Okay, but the deformity or defect is in the hemoglobin.
Yes, sir.
And the hemoglobin has got a modification. Is it clear for you?
Okay, sir.
Okay. See, when you talk about chromosome, that is the gene that is transferring the disease from the parents to the offspring. Okay. There is no alpha chain, beta chain there. There is only a short arm, long arm. Petit and long arm chromosomes with a exon and intron. All those things are there in the gene. Whereas once the disease is transmitted from the parents to the newborn or offspring, the modifications are done with the hemoglobin structure. And hemoglobin, adult hemoglobin has got 2 alpha and 2 beta chains, and here the defect is in the beta chain where there is a substitution of the
glutamic acid by valine, sir.
So that is the. So what is the difference between sickle cell and thalassemia, which is also an inherited hemoglobinopathy?
There is a deficiency of chains, sir.
There is a reduction or absence of the side chain, this hemoglobin chain, beta chain or alpha chain, as may be. Whereas here the chains are there, but there is a substitution. The structure is not normal. Okay,
Yes,
so that is the basic difference. So what are the types of patients you will get if you have a sickle cell problem? Are all sickle cell patients similar, or there are different types based on the genotype?
Heterozygous and homozygous, sir. And then
what do you call the homogeneous? What do you call the heterogeneous?
Heterozygous is called sickle cell trait, sir. In homozygous, sickle cell disease, sir.
Disease, very good. So which is more serious?
Sickle cell disease, sir.
Sickle cells. Homozygous offsprings who get a gene from both the parents, they are more dangerous people or suffering people. And what exactly happens because of the substitution of valine by glutamic acid in the sixth position of beta chain?
Beta chain during deoxygenation, this beta chain will get aggregate and will cause sickle cell
Polymerization. It's
polymerization.
polymerized. Okay. And loses its biconcave shape. The RBC, which is holding the sort of defective hemoglobin, it loses its biconcave shape and it becomes a sickle shape. What is the nature? Why the normal RBCs are biconcave in nature?
Sorry, sir. Why normal cells
Why,
biconcave?
why normal RBCs are having this biconcave structure or shape?
To pass through easily to the capillaries, sir.
Excellent, very good. So they are able to adapt and then pass through the small diameter micro vessels. They can squeeze themselves through that small orifice. Okay, but when it
Okay.
becomes sickle because of the polymerization, what will happen?
Occlusion in the capillaries, sir, in different
Very good.
leads to
So they will
ischemia.
clump together and form a microthrombi. They will form microthrombi and occlude the microcirculation. So what is this condition called?
Sickle cell crisis, sir.
Crisis, vaso-occlusive crisis. It can also be called as, to understand the pathophysiology, it is better to remember vaso-occlusive crisis or sickle cell crisis. So what are all the conditions stimulating or causing this vaso-occlusive crisis, and what are all the clinical features in such patients?
Hypoxia, dehydration, infection, acidosis, and hypothermia. Clinical features like episodic.
One more important thing, which causative factor as an anesthesiologist you have not mentioned.
Hypotension, sir. Pain.
Pain, you must, pain is very, very important. You should never forget pain. Whether it is occurring naturally or by injury or by surgery, pain is an important factor for precipitating a sickle cell crisis or vaso-occlusive crisis. So as an anesthesiologist, we are more interested in that. So dehydration, hypoxemia, hypothermia, pain. So first is pain. Okay, acidosis. All these things are causative factors for precipitating a vaso-occlusive or sickle cell crisis. So these are the etiologies. What will be the clinical presentation if a person develops vaso-occlusive or the sickle cell crisis? How will they? What are all the clinical features you will see in such patients?
Acute chest syndrome, sir.
Commonly, acute chest
episodic
syndrome.
painful crisis.
Is it a painful condition or a non-painful condition?
Painful conditions.
It's a very, very painful condition because it is causing ischemia, isn't it? So
Yes,
it's
sir.
a painful condition. It mimics a bone pain or a very deep pain. Okay? And the
Yes,
other
sir.
forms of presentation, it can be, as you said, it can be a stroke-like feature or an acute chest syndrome, ACS. Not the acute coronary syndrome. This is a acute chest syndrome. What are all
Yes,
the
sir.
features of ACS, that is acute chest syndrome?
Fever, fever, cough, dyspnea, tachypnea, hypoxemia,
Okay.
and ARDS, respiratory failures.
The patient may have infiltrates, they may have neutrophil increase. Okay. So it may mimic the picture of infection as well as ARDS, and patient will be in a very acutely distressed state. That is a life-threatening complication of acute sickle cell crisis. Okay. Or it can produce a symptom like
Yeah, DS.
hemorrhagic or an infarctive or what you call the ischemic stroke-like feature also can be there. Neurological deficit on one side. So these are all the presentations. So we are worried more about the sickle cell crisis, and we should avoid that. So even this can happen in both men as well as in women. Okay, but when it
Okay.
comes to a question of woman who is pregnant, what are all the causes or the changes that happen in normal pregnancy which can precipitate a sickle cell crisis in a patient with sickle cell disease, which is a homozygous trait? Why we are worried about that? Will they normally people with sickle cell disease, if it is diagnosed very early in their life, will they progress up to adulthood? Will they grow and live up to adult age and then become a healthy woman and get married, get pregnant, deliver? All these things, was it possible earlier?
No, sir.
No, they were usually before attaining adulthood, they used to succumb to this disease and die. But what factors modified and how they are able to survive and come up to the age of puberty, become a normal woman and get married and then able to conceive and deliver? What are the medical advancements we have made to make them survive and see through their normal life? How is it possible now?
Mm.
What are all the advancements in medical science that we have achieved to make these people live up to adulthood and lead a normal life of marriage and form a family, everything? Ramu, are you there?
Yes, sir.
Can you describe the advancements that we have made in medicine to make these people survive? What are all the treatment that you can offer if you diagnose a child with a sickle cell disease? First of all, how do we diagnose or distinguish between sickle cell trait and sickle cell disease? Any idea?
Electrophoresis, sir.
Electrophoresis. Very good. You know the answer. Excellent. So you can do an electrophoretic study and distinguish between the trait. Trait is a very minor condition. They don't exhibit all these complications. They can grow as a normal adult. Whereas sickle cell disease patients, they are more prone for all these complications. Okay. So if you have diagnosed sickle cell disease in a young individual or a newborn child or a growing girl, how can you prevent all the sickle cell crisis? Is the most life-threatening complication which they have to avert to grow normally. So how you can prevent that? How you can treat them to become normal and lead a normal life? What are all the options that you can give, or what are all the treatment you can offer them? Any
Support
chemical you can give? Any drug you
hydroxy
can?
hydroxy
Hydroxyurea. Very
urea.
good. What is hydroxyurea and what does it do?
It will increases the circulating level of hemoglobin F, sir.
Okay. Was it originally
Prevents
used for
sickling.
this purpose, or is it a drug which belongs to some other category for treating some other condition?
It used for gout also, sir.
Not for gout. It is an anti-cancerous drug. It was introduced in oncology, okay, as an anti-cancerous drug. But in lesser doses, they found that it can help people with sickle cell disease by making hemoglobin F instead of the deficit or the defunct hemoglobin that is present in the sickle cell disease, so that the shape of the RBC is preserved. So the sickling does not happen. Hydroxyurea prevents the sickling happening. So by giving this drug at the dose of 500 milligram every day, they have to take it lifelong. If they take it that dosage, they can survive. And if at all there is a crisis occurring in spite of this treatment, what is the option? How do you treat that?
Bone marrow
Supposing
transplant.
she develops a feature like stroke, this lady before her marriage, let us presume that the case that you have discussed should have been a sickle cell trait only because she has grown up without any previous complication. Only thing you have mentioned is she has had a transfusion at the age of 19 for severe anemia. Okay, so at the time we do not know whether it was diagnosed as a sickle cell anemia or a normal nutritional anemia. Okay? So if at all you diagnose a sickle cell crisis or an occlusive crisis happening, how do you treat or manage that? What are all the modes of treatment in treating an acute crisis?
Uh, Pain management, sir, with the
Very
opioids.
good. So how do you
And
manage the pain?
with opioids, sir.
Opioids, straight away opioids.
NSAIDs followed by
Yes.
opioids, sir.
NSA followed by opioid. Any opioid you can give. First thing is bed rest. It is an acute painful condition. Okay, so patient, if they continue to be ambulant, they will have an exaggerated pain. So first thing is bed rest.
Okay.
Second thing is adequate hydration.
Sir.
Keep their temperature warm. Coming to the analgesic part, you start with simple paracetamol, then go on to NSAIDs, and if it is not relieved by these two methods, then think of opioid. Which opioid you have to avoid in that? Can you give all opioids or you have to avoid certain opioids?
Fentanyl should be avoided, sir.
Not fentanyl. A convener, something like fentanyl. What is meperidine?
Meperidine, sir.
What is the other name for meperidine?
Pethidine, sir.
Pethidine. Yeah, pethidine should be avoided. Why pethidine should be avoided?
Epileptogenic.
Excellent. This is a very drug which can precipitate epileptic seizures like seizures. Okay. So
Okay.
pethidine should be avoided in these patients. All other narcotics can be used. Okay. So
Okay,
this is
sir.
the management and the most important management. These are all conservative management of the first order. But what is the ultimate treatment for an acute
Transfusion.
crisis? Yeah?
Uh,
Exchange transfusion. Okay, to
Transfusion, yes.
remove the trickling blood and infuse normal blood into the patient. So ultimate treatment is exchange transfusion. Okay, so you must remember these treatment step modalities. So hydroxyurea for normal life to make that RBCs normal and prevent trickling crisis. Whereas once if crisis occurs, you have to know the bed rest, the fluid, oxygenation, normothermia, analgesics, and finally exchange transfusion. These are all the various modalities of treatment for treating an acute crisis. Okay? So if the
Okay.
patient survives or does not get into all these complications, they can grow up to a normal person. And if they plan to get married and then they want to start a family, is there any advice to be given to these people? What is called pre-conceptual advice or counseling. Do you have to do any counseling for them? Yes,
No idea.
because once you have diagnosed sickle cell disease, it is a possible that if she gets married, this lady gets married, she may get an offspring who also suffers from the same disease.
Yes,
Okay,
sir.
so they have to have a good pre-conceptual. If she, without your knowledge, she gets married and then she comes to you for advice. Doctor, can I start a family? Can I get a baby? In that situation, the physician should have the knowledge to counsel them and tell them, first of all, you select a husband who is not suffering from disease, because if both the parents are suffering from the disease, there may more chances for the offspring to get the same problem, and that too with the homozygous trait, and they may land up as a sickle cell disease kids. So first counseling is to avoid marrying a person with the same defect, number one. Then if these patients are already taking all these drugs like hydroxyurea, and if they happen to have repeated transfusions due to repeated sickling attacks, what is the complication that can happen because of the repeated transfusions?
Increase in hematocrit.
Ah,
Uh,
are you worried about increase in hematocrit or something else? What will happen if you keep on infusing stored blood to a patient?
Infection, sir.
The
Hemolysis.
So when there is hemolysis, what will come out of the RBCs?
Hemoglobin will release and
Hemoglobin will come out. What does hemoglobin contain? What metal it contains?
iron.
Iron. So if lot of iron is infused into the patient, what will happen to that iron? When you have more iron than what is required,
Iron load.
iron overload will happen, isn't it? And on this
Yes,
overloaded iron, where will your all it go and get deposited?
in retina,
Retina.
liver.
Okay. Liver. The first thing is liver, then pancreas. Okay. So this excess iron deposition in various organs, what is the name of that condition?
Hemosiderosis, sir.
Hemosiderosis. Very good. So this is called hemosiderosis. Okay. And if it gets deposited in liver, it can produce liver damage. If it gets deposited in pancreas, it will produce a symptom like diabetes. What do you call that diabetes? Then excess iron is deposited in pancreas, and pancreas loses its normal insulin production. What do you call that condition?
No idea, sir.
Bronze diabetes.
Bronze
It's
diabetes.
called bronze diabetes. Okay. So these are all the complications of iron overloading. So to prevent that, what can you do? Supposing a patient goes for crisis every 2 months, and they require 2 or 3 transfusions to get out of that crisis, and this leads to iron overloading. How can you remove that iron, excess iron that is getting deposited?
Dialysis, sir. Hemodialysis.
Heavy metal, how do you remove it from the body?
Hemodialysis, sir. Or iron chelates.
Chelating agents. Like just like your Wilson disease, you have copper deposition in the body. So any metal, if you want to remove, you have to administer what is called chelating agents, which will bind with the metal and get excreted. So patient may be taking hydroxyurea to prevent the crisis and have a normal shape RBC, or they may require repeated transfusions, which will make them go into a state of iron overload. So to remove this excess iron, they may be taking what is called chelating agents also. So during your pre-conceptual counseling, you have to tell them that they may have to stop all these things, all these drugs for at least 3 months before they plan the pregnancy. Otherwise, what will happen? They continue to take hydroxyurea and the chelating agents and then get a baby during the first trimester. They are continuing to take these drugs. What can happen?
Congenital anomalies.
Yeah, teratogenicity. Any drug taken during the first 12 weeks or the first trimester, they can have teratogenic effects, producing abnormal mutations in the fetus. So they should be talked about that also. So the treatment for a patient with a known sickle cell disease starts from the time of preconceptual age itself. And once they have stopped all that and she becomes pregnant, what are all the complications that you can anticipate due to the normal physiological changes that happen in pregnancy, which will be exacerbated by the sickle cell disease? What are all the, first of all, enumerate what are all the normal physiological changes that happen in the various systems? Any pregnancy case, they will, in the examination, practical examination, this will be a very, very common question. So you have to rapidly answer all the changes that happen in the cardiovascular, respiratory, renal,
Okay, sir.
hepatic, musculoskeletal, every system you should be able to recollect and tell the answer. What are the changes in cardiovascular system?
In
And compare
cardiovascular
it with the
system,
patient with sickle cell disease.
cardiovascular blood volume increases to 30% and plasma volume will increases by around 45%, and cardiac output will increase to 30 to 50%. Heart rate will increase to 15 to 25%.
Okay. So these changes, are they going to affect sickle cell disease patient, or is it beneficial to them?
Beneficial, sir. Actually increases
Beneficial. So they are
plasma
not
volume.
getting dehydrated yet. They are getting actually little well hydrated. So these changes are not going to affect. But which change in cardiovascular or hematological system, which is likely to affect and cause problem if they have sickle cell disease?
Pregnancy is a thrombogenic state, sir.
Okay.
Increases coagulation factors.
Excellent, excellent, very good. So hypercoagulable state. So don't say thrombogenic. The word you have to use is it is a hypercoagulable state. Okay. So that can precipitate a coagulation in addition to the sickling. That is a risk. Very good, excellent. Anything else? What
Other
is
system.
physiological anemia of pregnancy?
Increase in plasma volume compared to increase in hemoglobin count.
Okay.
Leads to physiological anemia.
Anemia. So if the physiological anemia harmful to sickle cell patient, or is it boon to the sickle cell patient?
It's both. Is harmful because of decrease in hemoglobin, hypoxia, because of hypoxia, and
so by causing hypoxia or inadequate oxygen carrying capacity, it can precipitate a sickle cell crisis, isn't it?
yes.
So this physiological anemia is a harmful effect, whereas the increase in plasma volume is a beneficial effect. And the hypercoagulable state is again a harmful effect. Okay, so there are two harmful effects and one beneficial effect in the physiological changes that occur. Okay,
Yes, sir.
right. What about the respiratory system? Does it have any effect?
Due to increase in oxygen consumption and meat volume increases to around 50%, and PaO2 increases in 10%, but and the PaCO2 decreases 15% around. Decrease in FRC, sir. So early
That is the most important point. All other changes to maintain the minute ventilation, that is immaterial to us. But the decrease in FRC is always a dangerous thing for the pregnant mother, who can become hypoxemic at a very, very short spell of time. So that will precipitate a sickle cell crisis. So they should be encouraged to have deep breathing all the time, never lie in a supine position, which will impinge the diaphragmatic action and reduce the FRC further. So that should be advised to the mother. Okay, that is the only thing in the respiratory system. What about immunological system?
renal.
Patients more prone for infections.
Yes, sir.
Why?
Due to irritant smooth muscle relaxation because of progesterone leads to urinary stasis and urinary tract
That is
infection will occur.
normal even for a normal pregnant woman. This inadequate peristalsis of the ureter can cause
Due
stasis and
to also insulin resistance in
Hmm?
due to also increase in due to insulin resistance also there will be
Insulin
like
resistance. Is it the cause for infection in sickle cell patient? Which is the organ of immunity in our body? It belongs to the so-called reticuloendothelial system.
complement system.
Spleen.
Okay, sir.
Yes.
Okay, sir.
Spleen
Okay,
is a
sir.
very, very important organ, very much neglected. We don't study about it, but spleen belongs to a very, very important category where somewhere the immune components are produced. And there is a repeated patients who suffer from crisis, they go for splenic vein thrombosis and they lose their function of spleen. That it makes them more immunosuppressed, and that is why they can develop any sort of infection, not only your urinary tract infection, but they can develop pneumonia, they can develop other cutaneous infections. So any infection is possible. And one of the medical advancements that we have done to make these patients survive is give them vaccination against the common encapsulated organisms. So apart from hydroxyurea and transfusions, we are able to give them
Immunization.
vaccination to prevent them going in for repeated infections also. Okay. So immunocompromised, these patients are mostly immunocompromised. And again, because of this crisis and microthrombi, renal function also can get affected. So you have to check their urea and creatinine and make sure that kidney is functioning normally. Okay.
Okay,
And
sir.
so these are all the preoperative and musculoskeletal. They can get developed again thrombus or occlusion in the muscle, and they get both avascular necrosis of the femoral head is very, very common. So if
Okay,
you
sir.
have to put them on a lithotomy position for some procedure, instead of cesarean, you want to do a vacuum extraction. You want to put the patient in lithotomy. This avascular necrosis can produce a fracture also at the time. Okay, so you have to make sure that these changes have not happened in these patients, which is very, very important, right? So now
Okay, sir.
coming to the part of discussion on how to manage a category 1 cesarean section in this patient. Now this lady has come through all these problems that has never occurred or occurred mildly, and she has survived all that. She got married, she got pregnant, and she has now come to 38 or 39 weeks of gestation, and suddenly there is a fetal distress. And what are all the fetal changes that can happen in a patient with sickle cell disease? We have talked mostly about the maternal changes. So we have to know in what way the fetus can get affected, and what is the pathophysiology of the effects on the fetus. Supposing there is a micro-occlusion occurring in the placenta, will the fetus be able to grow normally?
I use here, sir.
It may have intrauterine growth retardation is very, very common unless you take proper care. And spontaneous abortions also are very common. Is there
Okay.
any treatment that can be advocated in these patients to prevent these problems? Do they have a normal placental circulation? These patients are more prone for preeclampsia and eclampsia also. Patients, because already they have this thrombotic tendency, tickling tendency. It is not mainly because of the coagulation factors, but it is mainly because of the occlusion from clumped RBCs. Okay. Anyway, they advocate 75 milligrams of or a particular drug after 12 weeks till the end of the gestation. What is the drug? I have told you the dose.
How much
Can you guess the drug?
dose, sir?
75 milligram OD. It is also called baby something for people with coronary diseases.
30 milligram. Yes.
Heard of baby aspirin?
Aspirin.
Aspirin, 75 milligram of aspirin, okay, can be given for these patients. After 12 weeks, again, you have to avoid this drug during the first trimester. And then starting from 12th week, you can give 75 milligram OD until they deliver the baby. Okay, so that is the treatment advocated now. And so fetal growth also has to be constantly monitored in these patients. And now she has come almost to the end of her pregnancy, and she has gone into a state where she requires a urgent cesarean section to deliver the baby and save herself also. So what anesthesia you can give for this patient with a known established sickle cell disease, but who has not had major crisis problems so far?
I prefer general anesthesia, sir.
You prefer general anesthesia. Why? What is the anesthesia preferred world over for normal cesarean section, patients with the normal physiology?
Spinal anesthesia, sir.
Spinal anesthesia is the accepted technique world over for any, whether emergency or elective cesarean section. But even in category 1 cesarean section, earlier the UK Royal College of Gynecologists and Royal College of Anesthesia, they said the only indication for GA was category 1 cesarean section. But now they have also modified that is not need not be GA all the time, but they have given an option for a different type of spinal anesthesia. What is that spinal anesthesia called? Jayabharti madam, are you there? Muteswar Rao garu?
Rapid sequence time.
Rapid sequence.
Excellent, excellent. Rapid sequence spinal. What is the difference between normal spinal and rapid sequence spinal? Excellent answer.
The nurse
Correct.
will scrub. Nurse will
Huh?
wash and scrub the patient. Nurse,
Yeah.
the attending nurse will
Yes,
wash and scrub the
you don't waste time. That is the idea of rapid sequence spinal. So, like a normal spinal, the anesthetist need not go and scrub for 2 minutes, then wipe his hand, put on his apron, put on his glove, and load the drug and then paint the patient and all that. While the anesthetist goes to prepare himself, wash his hand, the surgical assistant scrub nurse, she will prepare the back of the patient, she will get the spinal needle, she will load the drug and keep it ready. The anesthetist has to just come and palpate the landmarks and put the needle and give the drug so that you can save this time. So this is called rapid sequence spinal, which has been approved as one of the good technique for even category 1 cesarean section, which is earlier was done under only general anesthesia. Okay, so when that is the case, why you want to give general anesthesia? What are the advantages of spinal over general in any pregnant, say any cesarean operative delivery?
Pregnancy itself is a difficult airway condition, sir. So
Excellent.
preferred technique is regional.
Very good. One other point. So even if it is a class 1 airway, Mallampati class 1, mouth opening class 1, upper light but for class 1, neck movement class 1, even if that case, still you would prefer spinal, isn't it? Even if you don't anticipate any difficult airway at all. Even then, you would prefer spinal, isn't it, for any cesarean?
It's a full stomach condition pregnancy.
Aspiration. The main reason why they said spinal is the ideal technique for the cesarean section is because a pregnant woman is considered as a full stomach patient even if they have been electively starved for 4 to 6 hours because of the physiological changes. And many deaths happened in the earlier days when DA was the technique recommended for cesarean section. The maternal mortality inquiry in the UK showed that many deaths happened because of silent regurgitation in aspiration, even though there was no overt nausea, vomiting happening during induction. Okay, and that is the reason why they changed from GA to spinal. That is the first and foremost reason, not the airway difficulty. So you can definitely prevent aspiration in a conscious patient compared to a patient undergoing general anesthesia. That is the reason why the spinal is preferred as the first technique of choice for any cesarean section. Coming to this patient with sickle cell disease, Sai wants to give GA. Any reasons for that, Sai?
Sir, if we use spinal, there will be a vascular stasis in lower limbs, which precipitate sickling of RPC.
Stasis will it cause sickling?
Venous state.
Mhm. Mhm.
And will cause spinal will cause hypotension. Is also one
Hypotension.
contributing factor for sickling.
Okay. Which way, which kind of the technique will cause more bleeding, spinal or GA?
GA.
GS.
GA will cause more bleeding. Why?
Uh,
How do you maintain GA for a spinal, I mean cesarean section? Have you ever given GA for a cesarean during your training period?
yes, sir.
Yes. So tell me, how do you give GA for a cesarean section? Patient is on table, all monitors attached, IV line is there. Tell me one step by step what drugs you give to induce GA, what relaxant you use, how do you intubate, how do you maintain anesthesia, how do you recover the patient. Tell me all the steps. If you are given GA, you should be able to tell all this.
Small borders are attached, sir. And
I have told you all that. Monitors attached, IV is there. Tell me the drugs you will use. Induction,
first
intubation,
pre-oxidation.
pre-oxygenation. Okay, that is also done. Excellent. We have done the pre-oxygenation also.
Okay. I would
What is
induce
the
it
induction agent of
ketamine, sir.
choice? You want to give ketamine regularly for any GA. Patient is not in shock or anything. There is a increase in the fetal heart rate. So there is a, they say it's a fetal distress. That's all. So do you want to give ketamine for this? What is the normal drug used for induction for a cesarean section GA?
Propofol, sir.
Propofol, dipentone,
Neopentone.
pentothal. Have you seen pentothal? Is it being used now, or you have forgotten that drug?
No, sir.
Not
No.
available.
No.
So even today, pentothal is one of the ideal drugs. Okay, so you can choose between propofol and pentothal, no problem. Okay, so after the inducing and unconsciousness with this induction agent, what is the relaxant of choice?
Scoline, sir.
Dexamethasone. Okay, why do you want to use dexamethasone?
Pregnancy is considered as a full stomach. We have to
Stomach pain. So you want to do
rapid sequence
RSI,
intubation.
rapid sequence intubation. Okay, so because of rapid sequence intubation, you want to do, you want to use dexamethasone, which will act faster and short acting. Okay, what
Okay.
is like RSI? Have you heard of DSI? Anybody heard of DSI? And where is it practiced?
Delay
Very good. Delayed sequence
delayed intubation.
sequence intubation. Where do you use delayed sequence intubation? Opposite to rapid sequence intubation. Which condition you will use delayed sequence intubation? Venkateswar Rao,
Muscle
Bharati,
muscle relaxation
Non-complex.
or better muscle relaxation, sir.
there's a particular condition called nowadays talked about.
TMG oncology.
What are the types of difficult airway? You know,
TMG ankylosis.
PMG ankylosis. You can't even intubate in that case. You can't induce. The DSI or delayed sequence intubation, which is opposite to rapid sequence intubation, is done for what is called physiologically difficult airway. Nowadays, they have a category called physiologically difficult airway. Something like anatomical. All these days, we were talking only about anatomically difficult airway, where we wanted to see the mouth opening, the neck movement, the Malamati score, the upper lip bite test, the protruding teeth, all these things are anatomically difficult airway assessment. But nowadays, they have found out that physiologically difficult airway is also there. And in that condition, we may need to do what is called delayed sequence intubation, where in order to oxygenate the patient, you have to take time and oxygenate, because it's such an emergency or a very difficult situation where if you rapidly try to intubate the patient, invariably patient goes in for cardiac arrest at the end of intubation. So to maintain a good oxygenation, we give ketamine in that situation, make the patient wear the mask and bag and ventilate them adequately, and then do the intubation. So this is called the difficult sequence, a delayed sequence intubation or DSI, which is, so one of the short note question in the theory paper they are now asking is physiologically difficult airway. Okay, so that is by the side of it. Okay? Right. So you intubate the patient with Saksa, and if there is a common question is if the family history of Saksa apnea is there, what is the other alternative for Saksa?
Rocuronium, sir. Short acting.
Okay, right. This is a common question. That's why just I wanted to refresh that answer for you. So rocuronium can be used, and of course from there the examiner can take you to Sugammadex and all those things which we discussed earlier classes. Right. So after intubation, how do you maintain anesthesia? Because the patient will come out of both propofol or thiopentone within 5 minutes time, and the Saksa effect also will wear off. So how do you maintain anesthesia during the baby delivery and beyond that?
So maintain with inhalation anesthetics and muscle relaxants.
You want to maintain with inhalation agent. Which inhalation agent you want to use?
Sevoflurane is
Sevoflurane,
preferred.
not isoflurane, not desflurane.
Yeah, isoflurane can preferable, sir.
Isoflurane also you can use. Okay, so any volatile that is available you can use. What is the effect of this volatile on the uterus?
With the relaxation, sir.
It will cause more relaxation. So after baby delivery, will it hinder with the contraction or will it cause more bleeding?
Will cause more bleeding, sir. So
More
vitrectomy is oxytocin.
Okay. So that is the reason why GA is not, again, not the ideal technique. Okay. So that is the reason why we don't want to use GA as a routine for all cesarean sections, especially in this patient with sickle cell disease. Again, post delivery bleeding, postpartum bleeding also can get aggravated, and patient will become anemic, and the anemia will cause hypoxemia. Hypoxemia can precipitate a crisis. Okay, so these are all the sequence that you have to avoid. So the best technique, even for a category 1 cesarean section, here is a spinal, a combined spinal or epidural, whatever you want to do, you can do. But of course, epidural will take a longer time, so better to go for either spinal or combined spinal, which you can do faster, right? So that is
Okay.
the answer for all these questions. Post-op, what are all the precautions you have to take in this patient when they come for during post-op period?
Continuous monitoring, sir, for any
Ah.
hypoxemia, dehydration, pain, because these will precipitate again
So
sickle
the
cell.
same crisis can happen even in the post-operative period also. Okay. So just because you have delivered the baby, don't be relaxed. Monitor them in a high dependency area. Continue the hydration, and first of all, give adequate pain relief, because pain is a very notorious factor which can precipitate this crisis. So take care of the pain either by putting in an epidural after delivery also, or you can go for intrathecal opioids when you give the spinal, or you can give your routine other multimodal analgesic management, hydration, keeping the patient warm, and thromboprophylaxis is very, very important. So they advocate low molecular weight heparin. If it is a normal vaginal delivery, which also can be encouraged, you have to give a low molecular weight heparin for 6 days. But if it is for operative delivery, they recommend it for 12 weeks. That is 3 months post-op. The patient has to take low molecular weight heparin. Okay. So these are all the things that you have to remember if there is a question on how to manage a pregnant patient with known sickle cell disease. Is there time for me to show a presentation on this, Amachi?
Yes, sir. Yes, sir. You can.
I'll share my screen. Is it visible?